Welcome to our live stream, Duke Spine. We are now getting ready. I need the shoulders pulled. We're doing a patient with two herniated discs, 5-6-6-7. The 5-6 is the worst shot. Oh, very nice. And we're entering the disc now. Sorry about the late start. We had some technical issues. Can you give me a little inline? Almost done. Beautiful. A little bit more. Shot. Just a little bit more. We're almost there. Shot. Is that it? Shot. That's pretty good. Let me get a little bit more. Stay where, you guys give me a second. And we're going to go a little more. Shot. Shot. Oh yeah, that's nice right there. Yep. Almost done. You guys ready? And pull. Beautiful. That should be it right there. That's it. All right, beautiful. I lost the Raytech. You may have to give Luis a little pull because he's trapped.
Okay, ready?
Yeah, give him a little pull. Go ahead, Luis. 3, 2, 1. 3, 2, 1. Perfect. Thanks, everybody. Good work. All right. 2, 3, 4, 5, 6. We are at C5-C6. This is the worst disc, by the way. This is the biggest herniation. 6-7 is not that bad. And this patient was told by his doctor he needed a fusion done on his neck. That was his only option, like so many. And he didn't want to have a fusion. He told me that he was about to get the fusion done, and he was actually had already done all the pre-ops, labs and visit, and then he canceled once he found out about the Duke laser disc repair. He didn't want fusion. So here we are at the back of the disc, right where the herniation is. You can actually see the herniation there, right between the crack. See that? And now this is our 4th surgery for today. We do have one more to go. The last patient will be a cervical as well. And he's a 1 level. This patient is from Louisiana, right?
Yes.
The next patient is from Africa. She?
We're talking about a patient tomorrow.
Oh. Bernadette, great job today. I was impressed. Nicely so. Impressed in a good way. Folks, you have no idea. If you come to Duke Spine, how lucky you are to have a great anesthesia. Oh, your IV pole is still in the way. I'm like trying to figure out why can't I see this thing? You love putting that IV pole right where I'm looking, don't you? It's your favorite thing to do. Huh?
I'm thinking maybe we should have the bed a little bit further.
No, we can't put the bed a little further.
Okay.
No.
Because if I move the pole here, then stepping on the
You don't have to move the pole there. Put it back where it was. Put it back. More. Now lower it. 4 inches.
That's the thing. I think it's frozen.
No, it can't be frozen. If it's frozen, then we need a new pole.
Maybe do you have the machine that the problem? That's the only thing that will affect.
That's a nice herniation we just took out. Yeah, just lower it a little bit. If you can't lower it, then we need a new one. All right, there, still a little bit of herniation there. You can see it. You guys see the herniation? Right there, the white thing.
Yes, we
Then
do.
let's get a new IV pole. So again, like most herniated discs, I'm fighting the collapse of the disc and the scar tissue, mostly. It's really a lot of scar tissue at the back. I think we're a bit overexposed. Maybe we can tone it down a little bit. That'd be great. That's too much. No, just tone it down a little bit means one. One click. All right. I need you to give me, there's a herniation. I need you to give me one more click of up light. More light. Was that it? Yeah, that's it. So that's probably good right there. This is all herniation. See all the pieces? I'm trying to float them out. Hey, this fucking bag is not set up properly. Look at all the herniation there. You guys see it? The laser is
Yes, we
removing
do.
it.
How's that?
That's great, Dr. B. Thank you. So the other day we were doing telemeds and I had to introduce my telemed team to the A team. Remember? A team with Hannibal and Face, Mr. T, and that's a bone spur, by the way, right there. And who else was there? Face, Mr. T, Hannibal, and who was the crazy guy? Murdoch. That's him.
I think
Murdoch.
Henry's Murdoch.
Henry is Murdoch? Are you serious? Oh, Henry's not even here today.
Right. So I'm just
Uh-huh. I see how it is. Kick a man when he's down. Actually, Henry was at the work comp meeting. We had a good showing there. Apparently, other doctors were coming to our talk
I saw the
to
picture.
see what we were talking about. All right, we are in the foramen on the left at C5-6. You can see a lot of herniation here. And we're literally at the back of the C5-6 disc, removing pieces of herniation. Look at that big piece right there. That is a Moab. You know what Moab is?
Mother of all bombs.
Mother of all bombs. You come from Nevada. You got to know that terminology, huh? The Moab, mother of all bombs. Yeah. That's a big one. Man, look at all the smoothness of the surface. That's from inflammation. Working on it. Working it over. What a beautiful view though, huh? You can see the end plate there of C5 and the little bone spur here that I'm working on. The neuroforamen right out there. Real pretty. Well, I'm going to flip and come back my way towards his right because we got a lot of herniation to take out still. There's a big piece. Don't want to get greedy. Try to get it all out at once. You can see it moving, wiggling. Just going to take our time and do this right. Make sure we get it done well. So our patient was telling me that where he comes from, they don't do endoscopic surgery. They just do fusions. I told him that's pretty common. I hear that a lot. Unfortunately, it's not good for patients when they're not given a good option, a good choice. They're only told that fusion is the only way. Let's try to grab this herniations out. Our next patient traveled all the way from Africa to come here because he was only offered fusion as well. Which way was I? This way?
No.
No.
Yes.
Look at that herniation coming out right there. See how it almost came, but it was still stuck by some scar tissue? Now we're freeing it up. There it is. Here it comes. Good. These herniations to me look old. They look like they've been here a while. Okay? I'm going to say this. I've been inside of these discs for many years. I've seen these herniations for many, many years. And what I can tell you is it really helped a lot for me to do all the fusions that I did long before I was doing endoscopic surgery, because it really taught me the anatomy of the back of the disc. And I'm going to tell you something, a lot of spine surgeons don't get to the back of the disc. Many of the spine surgeons today are not trained to go back here and see what's back here. But this is where all the problem is. If you don't get to the back of the disc in spine surgery, you're not fixing the patient's problem. You got to get to the back of the disc. Look how scarred this is. All that white stuff. A lot of scar tissue. Bone spurs here. Bone spurs and scar tissue. Once again, not much herniation, not much fresh herniation, very old herniation. That's a piece of herniation right there. Yep. Gonna have to keep working it. Just sort of go back and forth. Any questions from the audience?
We have a comment from Love Peace on YouTube.
All right. I do love peace.
I pity the fool who don't use DLDR.
I love it. I pity the fool, Mr. T.
Who don't use DLDR.
Yeah, that's wonderful. Thank you for sharing. I love that. I was a big Mr. T fan when I watched the A-Team many years ago. I love Mr. T. I also really liked Hannibal. And one of my favorite sayings is, I love it when a plan comes together. You know, such simple phrases, but have deep meaning. The nice thing about the A-Team was it taught us how important a team is, right? It wasn't one person, they were a team. They worked together to achieve goals, difficult goals. And that was one of the things about the show that was so appealing, was the teamwork. Everybody had their function, their role, and it's really nice how the old programs like that teach us important values and principles in life, how to deal with situations. You know? A lot of the television programs of the 70s and 80s were very much focused on people working together to solve problems. Another one of my favorite shows at that time was The Dukes of Hazzard, right? And it didn't matter what show you were watching back in the 80s. The key message was work together as a team and get things done. Dukes of Hazzard was no different. Right? Thank you. So here I am as an adult working with the team every day, relying on each other. That's what I'm saying is those old TV programs were very, very useful in instructing people, young kids especially, on how they should work with others to achieve goals. Anyway, just my observations. Okay, making progress. A lot of stuff we're having to clean up back here. I want to see what's behind this. This is the biggest herniation for this patient, number 5-6. So we're going to spend a lot of time working this out, making sure we get as much of the herniation as we can. Remember what I told you folks, you're never going to get 100%. But herniations are tumors. Tumors are masses. A mass causes problems. So the more of the mass you get out, the more symptoms you can treat for the patient. You get enough of the mass out, and the patient won't have any more symptoms. Okay? That's the idea. Let's get as much of this mass as we can. You can see how the laser can be used to just peel literally little layers away. That's the posterior longitudinal ligament there, by the way, the PLL. You guys see it? Ooh, man, that's tough. Kind of popping around a bone spur there. Pretty cool. Making some progress. You guys see the PLL?
Yes, we do.
It's the fibers that are running. They're white. They're literally right there. I'm bouncing on them right there. That's the posterior longitudinal ligament. And normally that is behind the disc, but some herniations are so bad they go through the PLL, like right here. You guys see the herniation? Right here, going down?
Yes.
This is all herniation. It tore the PLL, and it made a giant hole right there. See this hole right here? And that's all herniation. Literally peeling off the herniation with the laser. Okay? I may want to cut through this PLL just to see if there's any herniation behind it, because it's totally incompetent. Have to be real careful going through the PLL, because if there's a herniation behind it, it's all good and fine. But if there's not, and you're talking about the spinal cord being back there, that's not going to be good. You don't want to go through the spinal cord. The nice thing is I could see pretty good. Now that looks like spinal cord right there. Okay? But I want to get as much of this herniation off as I can get. I'm going to bring the laser fiber back because it's just a little too far. I'm going to bring it back to the camera, which I just did. All right, and I'm going to come in and I'm going to peel this PLL right off. See how the fibers are releasing as I go over it with the laser? I want to see if there's a herniation behind that. Trying to see. That's peeling away 1/10 of a millimeter at a time. Pretty cool, huh? It just doesn't get any cooler than that. Not for a neurosurgeon. I can't tell if that's herniation or scar tissue right there. It looks like scar tissue. And there's another crack in the PLL. Still see some fibers there. They look pretty scarred up. Looking good. I don't see any more. There may be a little bit of herniation there. I'm going to take a look. Right there. See that? I think we've cleaned this up about, 70%. Just a little bit there. I'm going to extend my laser fiber just about 1/2 millimeter just to get a little more of this herniation that's in the foramen, just underneath the nerve root. It's in what we call the axilla of the nerve root. I don't think I can get any more. I think that's about as much as I can do. His chest is kind of blocking me because he's got that big barrel chest. What's that? I got some water. That was interesting. You see that? That was pretty cool. Got some water there. When I say water, I mean irrigation. All right, I'm going to try to extend my fiber. I'm going to try to pull back with my tube and see if I can't approach this a little different. There's a piece of herniation that was sitting right outside my tube. See if I can break it up. Good. These chunks are all herniation. Uh-huh. All right, I got just a few more seconds here and we'll be done with this disc. We're going to try to get the 6-7. Beautiful. Very nice. See all those pieces coming out? Yeah, we are clean. That foramen is clean. You see it? Totally clean. That's real pretty. Just a little bit of scar tissue, but no more herniation. All gone. Across the back to the other side, I don't see anything.
Lights on, please. Thank you.
Whew. All right, watch this, Luis. All right, we're going to do a little betadine antiseptic. We're going to move down to 6-7 next with the Duke spine slide. All right. Everybody ready for the slide?
Yes.
We'll need a little shoulder pull, not yet. We'll need a little inline traction. And we'll need a lot of help from God. He's got a pretty high collarbone. Shot. Is that it? All right, that's nice. Let me get this tube out. Leave the dilator there. Shot. Good, good. Mm-hmm. What? What's wrong? Are you talking to me? Here. Take it. All right. Okie dokie, artichoke. Let's see what we got. Shot. Beautiful. All right. Now I need a little shoulder action. And shot. That's nice. I think we got this. I am almost out. Shot. I feel it right on the edge. I'm out. Shot. All right. We just got to make it down. Let's get an AP. When it comes to sliding down the ALL to the next disc, look at that. I moved over. Shot. You want to try to stay right in the middle. Shot. Okay, good. Lateral. So I'm going to try to slide down. No, don't too much. Just, that's good. Hold on. Shot. That felt like I moved. I need a little better view. Shot. Pulling the patient a little too much to your side. Shot. I need an AP. Let's see where we are. He's got some big shoulders. No doubt about it. Shot. Is that it? Yes, so we're dead center, which is great. Now if I could just get a little more. Luis, I need you to get both shoulders. Yeah. Give me a count and shot. Shot. All right. You showed us before, Jordan. Where is that? You showed us before. You got to come south with the fluoro. You're too far north. Shot. That's a little better right there. Shot. Yeah, that's it. Right there. AP. Quick AP. Quick, quick, quick. These people are dying. And shot. Lateral. Yes, indeed.
Oh, yes.
Why didn't you give us that view before? All right, that's good. Relax, relax. Everyone relax. Yeah, it's beautiful. Jordan, you've been holding out on us. 2, 3, 4, 5, 6, 7. Now the good news is this is a smaller. Are you still relaxed? Shot. Oh yeah, it's perfect. He's still, as long as he's relaxed, great. But I'm feeling a lot of fighting with my tube.
It's got one twitch. Taking a little more? Or
Let's try. There it is. You see the tear? Show the tear. I think I can get this. Shot. Yeah, that's a tear. Shot.
give it a little. Here we go.
Yeah, a little. But no, he's not collapsed. Shot. He's actually good here. That's good. Let's put the tube over. He's not like degenerated and scarred up and collapsed at this level. He's just, because his collarbone is so high and his neck is so thick, that's what we're struggling with. Feels pretty good. Shot. Oh yeah, that's nice. That's real good there, Jordan. Doing a great job with that fluoro. I knew you had it in you, Jordan. I knew it. You just had to dig deep. Am I right?
You just needed that maneuver being flipped around like that.
Shot. All right, let's see if we can get in. We keep an eye, Luis. Little inline.
Ready? Here we go. Pop right
Shot. Okay, that we have to stop.
Right over
Hold on. Pull that back a little bit. Shot. That's better. So what it's doing is trapping. Hold this here for me. A little inline. Shot. Uh-huh. Let me hammer it forward. Shot. Yeah. Huh? No, it's okay as long as we don't go in any further. Little inline shot. Is that it? Shot. That's about as much as I can tolerate doing. Shot. I think that's really good right there. All right. Beautiful. We did it. Nice work, everybody. This disc is much smaller herniation, so it should be pretty quick. Let's hope. Any questions from our audience?
No questions.
There it is. The tear and herniation.
Thank you.
Beautiful. We got 10 minutes maximum. Berndes, 10 minutes. See all the herniation, guys? Little pieces?
Yes, we do.
Like I said to you before, herniation is not one piece, it's always many pieces. I would say average 20 pieces, if I had to pick a number, based on my years of doing this. Could be 25, could be 30. All right, thanks for joining us today. We do have one more. Our patient from Africa is going to have a single level DLDR and a DPR. Grab her. The DPR is C5-C6, the DLDR is C5-C6. See it? Oh yeah, got some nice pieces there. Any questions from our audience?
Yes, we have a question from James Mao on YouTube.
James Mao. Hi, James.
Dr. Duke, question.
Yes, yes.
If I'm experiencing tingling and numbness in buttocks and legs, is this usually from disc being herniated or from annular tears?
I have no idea, James. Tingling in the buttocks. I mean, there's so many things that can cause that. We need to do an examination. But it doesn't sound like an annular tear. It sounds like sacroiliitis or piriformis syndrome, something else. Doesn't sound like a disc problem at all. Man, this disc herniation's older than I thought it would be. Look at all the calcium. The gold color. Yeah, buttocks is rarely disc. The disc problems cause back pain, not buttock pain, or not buttock symptoms. Buttocks could be facets, it could be SI, it could be piriformis. But the one thing it rarely ever is disc. My advice is do a MRI review with me and let me figure out what it is. Great question, though. Almost done. 5 minutes. Our patient is under general anesthesia, meaning this patient has a tube down his throat and he is on the ventilator. The ventilator is just a machine that pushes air into the lungs. Of course, it's all monitored by our anesthesiologist, Dr. Berndes. This herniation's worse than it appeared on the MRI. There's a lot more herniation than I thought there would be. The MRI made this disc herniation look small. It's actually substantial, very big, much bigger than the MRI showed. Oh, come on. I'd say 5 minutes. Look at that. Big herniation just popped up. I don't know if I got it. Come on. Like I said, this particular patient was scheduled for a fusion, and then at the last minute he canceled with his surgeon. And he was told that fusion was the only way to fix the problem. But that's clearly not the case. Now, there's something wrong with the irrigation. Are you guys not monitoring that?
Yes, changing it now.
Come on. Can't do the surgery without good irrigation. Let me know when you're done. A lot of the fragments of herniation that come out of the tube during the procedure, did you switch over?
Yes.
Thanks. A lot of those fragments are small, you don't see them. Some of them are big, those are the ones you guys see. But the small ones generally are missed. They're hard to see, they're move so fast, they're so small, they just look milky. Man, God, this fucking thing. It's like the never-ending herniation. That was a big piece. That was about 6 millimeters. I mean, 6 millimeters doesn't sound very big, but for a disc herniation, it is. Yeah. Lumbar wouldn't be such a big deal. Cervical is different. Well, I think he's going to do quite well. I do think this herniation is worse than what we saw in his MRI. I think it's gotten worse. If you ask me, I think that's why it's worse. So that's why we ask people to get recent MRIs, because herniations, new herniations can happen, like here, or herniations can get bigger. And that's clearly what's happened. Of course, you don't want to overdo it and do the MRI the day before surgery. That's not really necessary, but it's not a bad idea either. Questions from the audience?
We have a comment from Love Peace on YouTube.
Sure.
Some MRI machines are not as strong as others.
Yeah.
3 Tesla is a strongest. 1 Tesla is a weak MRI, I learned.
Yeah. That's true, but it's not that important. What's more important is the technique rather than the size of the magnet, okay? I've seen 3 Tesla MRI with horrible pictures. If the protocols aren't good and the patients are run through very fast. What matters is you could get the best picture out of a half a Tesla, a 0.5, if it's done right. If you have the right coil and you have the right protocol. It's not the size of the magnet, it's how it's used. Yeah, this is a really good example of where the herniation has definitely gotten worse since the MRI review. You know? I'm quite shocked at how much herniation is here. Sorry, Berndes, it's taken me a little longer than I expected, but honestly, I had no idea that it had gotten this much worse. That's fascinating. I don't think I've ever gone in and seen a disc herniation better than the MRI, but always, if anything, worse, like what we're seeing here. It's a good thing we did this disc, you know? I was kind of on the fence about doing it, and I'm glad the patient did it. I'm glad I did it, because this is horrible.
We have a question from Alicia on YouTube.
Mm-hmm. Sure.
What would have caused it to worsen that quickly?
Well, I don't know when what's the date on his MRI, Jordan? Oh, he's construction. All right. Well, there you go. Lifting something. Well, we can't talk about that. Lifting something heavy. You know, something over 25, 30 pounds. When you have an annular tear, doesn't take much to push out more herniation. So he clearly had an annular tear, and the herniation comes from the disc squeezing out. And so he damaged his disc a long time ago, and then he's just been pushing out pieces of herniation with activities, regular activities. You know? Look at that. Yeah. Definitely worse. Yeah, it's a good thing we did this 6-7. Because when you look at his MRI, you might say, 6-7's not that bad. And then you do this surgery at 5-6 only, patient's going to come back, and 6-7 is going to be worse. Quite interesting. Anyway, almost done. 5 minutes now, doctor. You can see the back of the disc is cleaned out. I don't really see much more. There's a little bit over here, and that's it. A little bit of scar tissue from the herniation, inflammation. Looks good. 1 minute. Little bone spur.
Lights on, please. Thank you.
Well, that was quite an interesting case. We definitely found a worsening of the herniation at C6-7. It's a good thing we got that disc done. I was worried that we wouldn't be able to get it done because his neck is so thick at the base that sometimes it's really hard to get there. All right. And I'm going to show you the incision. See, he can go back to his neurosurgeon in Mississippi and say, look, here's my laser surgery I did. And the neurosurgeon's eyes are going to pop out because he's never seen anything like this. I remember the first time I watched the Koreans do this, the South Koreans, 17 years ago. I mean, I literally couldn't believe what I was watching. Right, Bern? There it is, 4 millimeters. You guys see the hole?
Yes, we do.
4 millimeters. That's it. No bleeding. I got it. You take care of that. Here. Great job. One more to go. The next one should be pretty quick. He's got a perfect neck, and we're just. How do you want to do the next one? DPR first. Sedate prone DPR. One. That'll take me like 3 minutes, and then flip them, intubate them. All right, good. All right, let's go ahead and type up your questions. I'll come answer them. Let's run a testimonial for our audience.
Copy that. Playing testimonial in 3, 2.
It is February 23rd, 2022, and I'm here with one of my patients who's traveled from Kansas. Is that correct?
That's correct, Wichita, Kansas.
Wichita, Kansas, and clearly you've had surgery. We just did it less than 24 hours ago. You've got your incision there on your neck. How are you feeling today?
Much better. Much, much better. 26 years ago, I had a fusion of C6 and 7. They told me in Wichita that I would need to have fusions of C4 and 5 and C5 and 6. They set up the surgery for the 23rd March, and I'm going, I can't wait that long. This thing hurts, it's killing me, I cannot sleep, and so on. My husband Dale did a whole batch of research online, and he says, I want you to be able to move your neck after surgery.
Yes.
And
I did a
he
lot
did
of
a
Googling.
lot of research, and we found Dr. Duke to be a man of integrity. He films all of his surgeries. He puts many of them online, and you can see for yourself all the good work that he's doing, and that he really, really likes to help people. What he does is generally not covered by Medicare and not covered by some other insurances, but it very well should be, because it really helps people.
So what was life like for you before surgery?
My pain was mostly in the neck and shooting down my shoulder, and especially in my shoulder.
And you had really bad weakness with your arm. You couldn't even lift your arm, right?
That's
Before
correct.
surgery?
That's correct.
Show us what you can do now.
Before surgery, I could lift it to about here, and now I can lift it.
All the
Yeah,
way up.
just the next day, right
You couldn't
after.
do that before.
Yeah, that's because she had a herniated disc, two of them, C4-5, C5-6, and the herniations were literally sitting on the nerve. And we got in there, and if you watch this video segment right here, you can actually see there's the laser, and as we're removing the herniation, it literally pops right out of the foramen where it was sitting on top of the nerve, crushing the nerve. So, and the surgery was a success. We lost almost no blood at all, and you can see your incision is tiny. And here you are one day after surgery. It was outpatient, and you're ready to go home, right? You guys flying
Going home
back
tomorrow.
tomorrow? Okay, very good.
Try and enjoy a little bit of Florida today before we go back to the snow.
Okay, it is snowing there, huh, in Kansas?
Probably.
Okay.
If not today, then tomorrow.
Well, stay another week.
And yesterday it was 70
I
degrees
wish.
there.
70 degrees where, in Kansas?
Or maybe that was the day before it was 70 degrees, and
nice.
then they woke up to about 11 degrees.
Ah, so the cold front came in. We get those from time to time, and it gets cold around 60 degrees. Well, most of the time it's very pretty here in Florida. Well, we're glad you're here. Is there anything else you want to say to the world about herniated discs in the neck and surgery?
Dr. Duke will give you a free look-see on the MRI. It's well worth your time. And he will do a Zoom call with you and tell you what he can do for you. So go for it.
I said that it was so important that I said I'd pay for it. You know, because we got a little bit of a nest egg, and sure it's going to cost a little bit, but it was worth it because we got results. I mean, that's amazing.
Your health is the most important thing in the world, people's health. So
You can't take it with you when you
yeah.
pass away.
All right, folks. We'll have a safe travels back.
Thank
Great
you.
to see you. Glad we can help you out. That's a nice.
Thank you.
That's a nice shake.
And I hope you enjoyed hearing from her. She was a wonderful surgery and a great result. So we've just finished fixing a patient's cervical disc herniations. And the most common herniated discs are in the lower back. We call them lumbar disc herniation. The most common disc to be herniated in the lower back that causes symptoms is L4-5. L5-S1 is second, L3-4 is third. In the neck, the most common disc to be herniated is C5-6, followed by 6-7, followed by 4-5. In the earlier case today, we did C4-5, 5-6. This case, we did C5-6, C6, 7. The next case, which is coming up next, our patient from Africa, we're doing C5-6. Now, most spine surgeons are taught to do fusions when patients have a herniated disc in the neck. The alternative treatments would be an artificial disc, which they don't work well, they pop out, they fail, they cause problems. I don't recommend them. I used to do a lot of these fusions, like literally probably 5 a week on the neck, and then lower back I'd do others. I've done 1,000 anterior cervical discectomy infusions in my career of 26 years. I will tell you that the laser surgery is 100 times better than a fusion. There's no metal, and I want you to understand what we're doing. I'm coming with a needle, and I'm entering through the anterior longitudinal ligament, and I go into the disc like that. And if you look there in the foramen, you can actually see, I'll poke out the back there. I don't know if you can see it, but you can probably see it through there. You see where the needle has poked out the back? You guys see that? That's what we're doing. We're literally going through the disc with a skinny little tube, poking out right at the back where the tear and herniation are, and I'm using the laser to remove the herniation and clean the tear. Now in this patient's case, he had like 30 pieces of herniation. It was never ending, it seemed like. and I kept lasering and lasering, and more herniations were coming out of the back. But that's where the problem is. It's the back of the disc, not the middle, not the front, not the whole disc. It's quite literally a tear in the wall in the back, and the pieces of herniation come from the nucleus. They push out, and then you create inflammation, you create pressure on the nerves and the spinal cord. We went in there and did a decompression. It went really well. The only surprise for me was that 6-7 had so much herniation. Looking at the MRI, it wasn't bad. Looking inside with the scope, it was a lot worse. Any questions?
No questions.
I hope you enjoyed our broadcast, and we'll be back in 30 minutes with our last surgery for today. A patient from Rwanda who's having a single level cervical disc herniation fixed, and the Duke plasma rhizotomy at 5-6 in the back. Have a great night.